Good evening, everybody. Good evening. So just would like to check in and see, how many of you, is this your first time here, your first timers? All right, well, we want to welcome you to this presentation. And to get us warmed up here, we're going to talk a little bit about some famous people who have had Alzheimer's disease or have Alzheimer's disease and see how well you can identify them. So we'll start easy up here. Let's just move across. Shriver, right, very good. Jack Lord of Hawaii Five-0 fame. Yeah, we're going to skip her a minute. Who's this? Yes, good job, Perry Como. Yeah, and here? Yep, that's right. Edmund O'Brien. How about right here? Do you know her name? No. What famous TV show did she play in? Bewitched, right. Her name is Mabel Albertson. How about going down this way? Who's this?
Jean Barry.
Yes, very good. Jean Barry? Oh, somebody over here has seen these before. No, how about this person?
Star Trek.
Star Trek, yes. Star Trek, yes. Scotty, yes. James Doohan.
Jim Stewart.
Jimmy Stewart, Yes, Peter Falk. Now, this table is going to be quiet for a little while, and they're going to let everybody else guess. All right, who's this? Yes, good, Sugar Ray. Sugar Ray. Sugar Ray. How about right here? Yes, over here, Norman Rockwell. This way? Rita Hayworth up here? Yes. 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 You guys could only stay quiet for one, and then you just had to bust out. Who's this? Burgess Meredith. Somebody over there said it.
Charles Bronson.
Charles Bronson. And now we got one more here. Yes, Dana Andrews. And now there's two living people on this slide. And the first one is, do you recognize her? Yes, Pat Summit, Coach Pat Summit. And then here, Glenn Campbell, excuse me. All right, good job. The Alzheimer's Association just released its 2016 Facts and Figures report, and you can see that today in the United States there's 5 million people affected with the disease. 5.2 million of those individuals are 65 years or older. Approximately 200,000 are under age 65. So what that breaks down to is that 1 in 9 people age 65 and older have Alzheimer's disease, and by the time you reach 85, 1 in 3 people have Alzheimer's disease. It's estimated that in 2016 alone, 475,000 people will develop Alzheimer's disease, and a new case of Alzheimer's disease emerges every 66 seconds. So by the time we get done tonight, 2 hours will pass and another almost 120 people will be affected. 15.8 million caregivers, as you can see on the slide. So three close family members or friends assist in the care of every one person with the disease. And the total value of the care that they provide is valued at $221.3 billion that they contribute to our society. And when we just look at out-of-pocket costs for health care, meaning those services that are covered by Medi-Cal, Medicare, long-term care insurance, that you pay out-of-pocket for health care, the cost right now is $236 billion, expected to increase to $1.1 trillion by 2050. And today, Alzheimer's disease is considered the 6th leading cause of death in the United States, and we'll be coming back to that particular statistic later.
So this slide, this slide shows the projected numbers of Alzheimer's patients and how things will change by the time we get into 2050. So as Cordula was saying, the numbers have increased steadily over time, and it's estimated by 2050 that we'll have almost triple the number of cases we do today. So there's 5.4 today. It's estimated to be around 14 million cases by 2050, and some estimates, if there's not a cure or some way of actually preventing the disease, that number could go up to 16 million cases. And probably one of the fastest growing groups are the baby boomers. And Cordula and I are both baby boomers. We were born between 1946 and 1964. And it's estimated that 1 out of every 8 baby boomers who is age 60 and older today will probably develop Alzheimer's disease. And 1 out of every 6 baby boomers today who are age 60 will probably have a dementia of some type. So if you look at California, I think that may be coming from there.
Yes, from here, right? Yes.
You may need to actually change your chair if the light's too bad. Okay. So looking at California, 1 out of every 10 Alzheimer's patients in the United States lives in California. So what does that tell us, other than we have to be careful on the roads? Well, we have a large number. The 2016 numbers said that in California, right now, there's about 610,000 Alzheimer's patients. And that's going to increase to this 840,000 by 2025. And it's estimated that soon after 2030, we'll have over 1 million Alzheimer's patients just in California alone. Orange County, the estimates from the Alzheimer's Association last year were there was about 75,000 individuals who were affected by Alzheimer's or at risk of developing Alzheimer's disease, meaning they had mild cognitive impairment, which we'll talk about.
So this is a rather astounding slide showing the increase in the number of deaths due to Alzheimer's disease in the last 13 years, or I should say specifically data available for 2000 to 2013, so for that 13-year time period. And you can see that the percentage of change here in terms of the number of deaths has increased 71% for deaths due to Alzheimer's disease, while at the same time the percentage or proportion of deaths due to other major killers has decreased, including stroke, prostate cancer, breast cancer, heart disease, and HIV. So a number of factors may contribute to that. It may be the aging of our population. It may also be that we spend a lot less on research as a nation on Alzheimer's disease than we do on some of these other major illnesses. And there have therefore been more treatment advances.
Well, it's always been rather difficult for statisticians and scientists to determine the number of people who die each year from Alzheimer's disease. And that's because of the way the death has been recorded, particularly in death certificates. So in 2013, the Centers for Disease Control and Prevention, they looked at death certificates where the actual cause of death was listed as Alzheimer's. And they counted them up, and there was about 85,000 cases across the United States. But one of the problems with that is that many patients with Alzheimer's disease die from acute problems such as pneumonia or heart failure. And on the death certificate, it might say the cause of death was pneumonia. It didn't matter that the patient was maybe in a nursing home in the severe stages of Alzheimer's, the death would be counted as pneumonia, not Alzheimer's. So they actually went back and they looked at, they did a project where they looked at the number of death certificates that was due to Alzheimer's disease, like the 85,000, versus the number of deaths with Alzheimer's, meaning they could have had pneumonia, but they also had Alzheimer's disease. And the estimates are, when you use that way of counting deaths, in 2016, the number of deaths from Alzheimer's will probably be 700,000 cases, much different from the 85 that was listed with Alzheimer's as primary.
So actually, 1 in 3 seniors dies with Alzheimer's disease at the time of their death. So what are risk factors for Alzheimer's disease? So what's due to nurture versus nature? So we're going to talk briefly in the next few minutes about these risk factors that you can't change. There are several of them. We can't change how old we are. We can't change our genetic background. We can't change our sex, gender, and certainly if one's afflicted with Down syndrome, that can't be changed. There are many factors we can impact, and actually in the third part of this lecture tonight, we're going to be talking about some of these medical and lifestyle risks and what you can do to reduce your risk for developing Alzheimer's disease. But for now, we're going to talk a little bit about the risks that you can't change. So first of all, take a look at this data on life expectancy. There's been a tremendous change over the last 8 decades represented here in terms of how long one might expect to live. Actually, it's 7 decades. So in 1940, as a white woman, I would have been expected to live around 49 years, 48 to 49 years. Today, I can be expected to live 81 years. So when we look at that, the increase in life expectancy for those of us who are Caucasian has increased 66% in those 7 decades. For those of us who are African American or Black, that expectancy has increased 125%. And so we'll talk about how that impacts Alzheimer's disease. As you can see, one of the reasons there are more people with the disease is because the older you get, the more at risk you are. So in other words, the prevalence or the number of people affected by Alzheimer's disease doubles every 5 years after age 65. So between age 65 and 70, it's 5%, 70 to 75, 10%, doubling again at age 75 to 80 to 20%, doubling again after age 80 to 40% or even more. So the older you get, the more likely you are to have the disease. For those who live to be 100 or older, the estimates are that as many as 75% are affected by Alzheimer's disease.
Another risk of the disease besides just age is gender. And on an earlier slide where we showed the increasing number of cases, 2/3 of the cases of Alzheimer's disease are going to be women. If you look at the lifetime risk of developing the disease as shown in this chart, what you can see, the lifetime risk is the probability of a person at a given age will develop Alzheimer's during the remaining lifespan. So if you look at a healthy woman who's age 65, she has a 1 in 6 chance, or about 17.2%, of developing Alzheimer's disease in the remaining portion of her life. A healthy woman who's currently age 85 has about a 1 in 5 chance of developing Alzheimer's disease during the remaining portion of her life. And you can see these are considerably higher, almost double what you see in males. So why are there these differences? Well, one reason, as Cordula showed on just the previous slide, women tend to outlive men. So the good die young.
I don't know about that.
So one reason is women tend to outlive men, but there's also some genetic and lifestyle cultural issues that come into play, and we'll talk a little bit about that as we go on. Another issue that is a little bit unclear is, are there any differences in the risk of Alzheimer's due to race or ethnicity? And although there's many more Caucasian whites who have Alzheimer's disease than other minorities, it appears from research that African Americans are about twice as likely as whites to have Alzheimer's, and Hispanic Latinos are about 1.5 times greater risk of having Alzheimer's disease than are Caucasians. There's really not enough research out there to look at other ethnicities such as Asians. It's expected, as shown in this slide, that the number of particularly Hispanic and Asian individuals with Alzheimer's disease will more than triple by 2050. So we'll see a tripling in the number of Latino, Hispanic, tripling in the Asian Pacific Islander, and a doubling in the number of African Americans by 2030. Why is that the case? Well, it's unclear if it's due to any kind of genetic issues. That's unsure. It appears more likely to be related to lifestyle and also cultural issues. So, for example, in the Hispanic population, their average life expectancy is going to exceed that of Caucasians. So the average life expectancy of Hispanics by 2050 is going to be about age 85, which will actually be above that of whites. So as we know, Alzheimer's is an age-related disorder, so we'll see an increase in the number of Hispanics with Alzheimer's simply because they'll be living longer. Also, education is a risk factor, and unfortunately many Hispanic Latinos have less education than do Caucasians, and we know that individuals with less than, say, a 6th grade education are at double the risk for having Alzheimer's disease than if you have more education. And the other risk would be greater incidence of vascular problems and diabetes, particularly in one ethnic group versus another. And that diabetes particularly seems to be true for not only the Hispanic, but also Asian American and African Americans. So some of this difference is probably related to lifestyle and health issues.
So now let's move on from age to genetics. So there are two types of genes that are related to Alzheimer's disease. The first type is called deterministic. That means if you have the gene, you'll definitely get the disease. The second type of gene is a susceptibility gene. If you have that particular gene or those particular genes, it means it increases your risk. Now, if you look on the slide, you'll see that only a very small percentage of cases of Alzheimer's disease are due to deterministic genes. So only really about 1 to 3% are due to each one of those deterministic genes. And most of the cases where there's a deterministic gene involved are in younger onset individuals who have the disease, or the onset of the disease is before age 65. Now, in families with the mutation, the genetic one of these deterministic mutations, Alzheimer's disease is carried as a dominant trait. So that means your offspring has a 50% chance of inheriting the abnormal gene. So just to give you an idea of 1%, for example, the APP gene, which is on chromosome 21, is only found in 25 families worldwide. Most frequently studied is this susceptibility gene that we're going to talk about right now, called ApoE4. And it appears to be a risk factor for the disease after age 65. So first of all of us carry the ApoE gene. It actually comes in 3 different forms or alleles, and that's ApoE2, ApoE3, ApoE4. As you can see, this gene is important for the transport of cholesterol. Now, each of us will inherit 2 copies of this gene. And so we can inherit a 2, a 3, or a 4 from each one of our parents. So that means there's 6 different combinations, as shown as the slide. Now, ApoE2 is relatively rare. As you can see here, yes, Malcolm's pointing to it, it accounts for only about 5% only about 5% of people, have the ApoE2 form, okay? ApoE3 is the most common, which is carried by 61% of individuals, and then ApoE4 is the variant that is associated with increased risk. But you can see only 2% of people have an E4 and an E4.
But about 40 to 60%, or almost half of Alzheimer's patients carry an E4. So even though E4 is relatively infrequent in the general population, it's about half of the patients carry that gene.
So how does ApoE4 affect your risk? So having 1 copy of the ApoE4 gene essentially increases your risk of developing Alzheimer's disease 3 to 4 times compared to those individuals who do not have an E4. Having 2 copies of the gene actually increases your risk about 10-fold. And gender does seem to have a role here, where being a woman with an E4 increases your risk much more than if you're a man with an E4. Having E4 also increases the risk of developing the disease at a younger age than those who have an E2 or an E3. So it's unlike inheriting a deterministic gene where you're going to get the disease. With ApoE4, it does not guarantee that you're going to come down with Alzheimer's disease. It does mean that you're at a much greater risk of developing the disease. And it's important to remember that about 50% of people who develop Alzheimer's disease don't have an E4, all right? So even though the ApoE genetic test is very inexpensive, we really don't recommend you're having it for a couple of reasons. Number 1, we don't have a specific treatment that we could give you, and number 2 is it could really affect your insurance. For example, qualifying for long-term care insurance if it was in your medical record that you have an ApoE4 gene. So let's talk a little bit about how the brain changes in Alzheimer's disease.
time to just talk a little bit about the brain and the different areas, because we'll be coming back to that later on. So I brought my brain. It's a convenient model that I can replace anytime. So this model here is about twice the size of a real brain. A real brain is more about the size of a medium cauliflower that you could hold in your hand. And it would probably weigh about 2.5 pounds. But the brain is, although it's small when you consider our total body weight, the brain is a very complex organ. There's estimated to be about 100 billion brain cells in the average brain. And each brain cell can contact as many as 7,000 other brain cells. So you have about 100 trillion interconnections. So 100 billion with 100 trillion synapses or connections. The part of the brain that seems to be affected mainly in Alzheimer's is this area that lies along the side, just a little bit above where your ears would be. This is the temporal lobe. And the temporal lobes, we have a left and a right temporal lobe, and they're the lobes that are involved in learning and memory. Other areas, well, the part of the temporal lobe that is most affected is an organ called the hippocampus. And the hippocampus is Latin for seahorse, and it sort of goes all the way through our temporal lobe. And that's the area that is crucial for learning and memory to occur.
All right. So I like this particular illustration of what Malcolm was talking about in terms of our neurons or brain cells and how they actually communicate and connect with each other. You can see in a healthy situation and a person that's impaired with Alzheimer's disease. If we think about this in a very basic way, we could use the analogy that one of my hands is one of those cell bodies right here, and my fingers are like the branches, and my other hand is another cell body, and my fingers are like the branches. And as Malcolm said, they're synapses or points of connection. The cells don't actually touch each other, but there's a little gap there, and the electrical charge comes down one cell and jumps that gap. There's some chemicals that help that happen, or neurotransmitters, and then the electrical charge proceeds. But what happens in Alzheimer's disease, and you can see these formations that develop, they look a little like tumbleweeds, but what do they do? What do they do to those branches? They basically destroy those branches, so those connections are destroyed, and the cells can no longer communicate with each other. So here we see at autopsy the brain of a person who is normal or healthy versus one with Alzheimer's disease. And again, it's a side view of the brain similar to the one we showed before, with that temporal lobe right here over your ear. So you can see these hills and valleys in the brain and how they're also nice and tightly compacted. Now the person with Alzheimer's disease, again, look at, these are competing here, little pointers, but Malcolm's pointing. You can see, again, the temporal lobe. You can see how those hills and valleys have spread out, and there's been a lot of shrinkage, or what we call atrophy, and that's due to the loss of cells, or the destruction of the cells in the brain, the neurons in the brain. Now on the bottom we have actual brain tissue at autopsy that's been magnified under a microscope, and you can see that of a person with Alzheimer's disease does look quite different. And it has two abnormal structures that form, and we're going to show you more close-up pictures of these. And first of all, we're going to show you a picture of a senile plaque. So these are these spherical formations around the outside of the cell. They're made up of a toxic protein called beta amyloid. It's a very sticky substance that clumps around the cell and destroys the cell from the outside. And you can see in this illustration, again, those branches that come out from the cell body and how the plaque is destroying these branches and then destroying the connections between the neurons. So then we're going to go ahead, Malcolm.
The other pathological feature you see besides the senile plaques, which are composed of an abnormal protein called beta amyloid, you also see what are called neurofibrillary tangles. And neurofibrillary tangles, unlike the senile plaques, they are inside the neuron. And they're formed of an abnormal protein called tau, T-A-U. And these proteins, they occur in these axons, or these long extensions, sort of the arms of the brain cell. And this brain cell, this axon here, if you were to sort of blow it up, it's not like a hollow garden hose, but rather in the next slide, what it is within this axon is hundreds, if not thousands, of what are called microtubules. These are little tubes that information is passed back and forth along the axon in the nerve cell. The information also, along with other products that are necessary for the cell's existence and life. And tau is a protein that helps to form these little microtubules in a nice, consistent structure. So they're these sort of little binders that keep the tubules together and well organized and flexible. Some of these axons can be very long. In the human body, you can have axons that are longer than 1 meter in length. And they have to be flexible, they have to move with your body. What happens in Alzheimer's disease is shown in the next slide. And what happens is that this tau, which are sort of like the little binds that tie the microtubules together, this becomes affected, and as a result, these little binds or ties break apart. And as a result, it's sort of the analogy to like a railroad track, where the tau is forming these little, walking on the word, ties. Yes, railroad ties. And the information can pass along like a little railroad car, but when the tau is affected, it becomes hyperphosphorated. Then what happens is that these railroad lines sort of become all twisted, and as a result, just like in a real railroad, if the ties are broken, the tracks become inoperable. So there's some controversy about which of these things occur first. Do the amyloid plaques occur first, or do the neurofibrillary tangles? And there's been quite a discussion over the years, probably the last 30 to 40 years, about which one occurs first, and it's still unclear. But we do know that this formation of amyloid plaques starts years, if not decades, before any clinical symptoms appear. And normally a healthy brain, we all have this amyloid, by the way. It's part of the normal life and death of the cell. And these little fragments break off, and they're essentially removed quite effectively in a healthy brain. The brain sort of washes them out. In a person who has Alzheimer's, they have a problem with the clearance of this amyloid. So the amyloid doesn't get cleared out, but rather what happens, it starts to clump together into these senile plaques. Which is occurring first is unclear, the plaques or the tangles. We do know, for example, that most healthy adults will have some plaques in their brain as they age, and if they had an autopsy, we would see them. Generally, you don't see many tangles.
All right, so how can we measure these biomarkers? Biomarkers are biological signs, so we're talking about how do we measure amyloid beta and tau, specifically in a living person. And now in research, there's 2 ways that are being used to measure the amyloid and the tau in living people, and those are specific through cerebrospinal fluid and also what's called amyloid PET imaging. So we're going to talk about each one of those a little bit. And first of all, we want to talk about cerebral spinal fluid. And Malcolm was saying how in a normal brain, the amyloid gets washed out. And cerebral spinal fluid actually plays a role in it. It's a clear, watery liquid that's produced in a region close to the center of the brain. And so the CSF actually bathes the brain and provides some support and cushion. And it's constantly being reproduced and also eliminated. So the fluid removes various waste products from the brain, including helping to clear out some of this toxic beta amyloid. So one of the ways we would measure the brain changes would be by taking some cerebral spinal fluid from the person through what's called a lumbar puncture. And so how a lumbar puncture, I can't say that word tonight, is done. It happens, first of all, it's an outpatient procedure, and you go into the doctor's office, and the first thing the doctor will have you lie on your back like this, and will numb the skin around the area where the puncture is going to occur, and then inserts a very fine hair-like needle between the vertebrae in your back and draws out some of the cerebral spinal fluid. And the amount that's drawn out is very small, and your brain really quickly replaces the amount that's drawn out. Typically, there's no adverse side effects. Sometimes people will get headaches, but that typically only happens if the person gets up too soon. So typically it's recommended that the person stay lying down for about 40 minutes to an hour after the procedure. So because this beta amyloid is in the cerebral spinal fluid and it's being washed out, it's a place where we can measure it. So when we look at how we measure it, it's very interesting. When we look at the levels, what's actually happening in terms of beta amyloid is that in the cerebral spinal fluid, the level is low for beta amyloid as compared to individuals who are healthy. Well, why would that be? Well, the beta amyloid's staying stuck in the brain. It's forming those plaques. The cerebral spinal fluid isn't washing it out. That clearance process Malcolm was talking about isn't happening, so the level's going to be low in your cerebral spinal fluid. And then in comparison, you can see the levels of tau are actually much higher in cerebral spinal fluid in people with Alzheimer's than in healthy controls. And we have to measure both of these because when you look at only amyloid beta on its own, there's other diseases like bacterial meningitis and Creutzfeldt-Jakob disease or mad cow disease, where you'll see changes in amyloid beta. So we're really looking in changes in both of those: low amyloid, high tau.
And once to repeat it, just the amyloid is sticking in the brain, and that's why it's low. The tau is high because the tau is representing the disintegration, essentially, of neurons and the breaking them up. Now, these amyloid issues and tau, the neurofibrillary tangles, they tend to start first in that temporal lobe. In fact, there's an area on the bottom of the temporal lobe called the entorhinal cortex, or the old smell brain. And this is where these plaques and tangles tend to be seen earliest, sort of on the underside of the temporal lobe. And then they spread into the medial temporal lobe where the hippocampus is. And as the disease progresses, they will spread to the back into the parietal lobe that is involved in some of our language and visual spatial abilities, and also into the frontal lobes, which would be involved in things such as planning, organization, judgment, multitasking. So the distribution of these plaques and tangles, they tend to follow a relatively orderly sequence from the temporal lobe into the other regions. Late in the disease, you may have extensive damage due to plaques and tangles throughout much of the brain, with the greatest concentration still in the temporal lobe and hippocampus. We mentioned about the CSF, cerebral spinal fluid test. We can also look at amyloid, and more recently, even you can start to look at neurofibrillary tangles. But the way that we have to look at amyloid plaques is a new technique. It's called an amyloid PET scan. And this is a technique that was first approved by the FDA in 2012. So not that long ago, about 4 years ago. What it entails is this particular type of a scan is called an amyloid scan. And so amyloid is a radioactive agent that is injected into the carotid artery, and it goes up into the brain, and this agent latches on to the amyloid in the brain. And when you do a PET scan, you can actually detect where the amyloid is forming. And so this is a comparison of an Alzheimer's patient brain. This is looking down on it. So this would be the face up here, and this is the back. And you can see the amyloid, which is shown by these bright red and yellow colors, is quite extensive compared to a similar age normal adult. So one way we can look at amyloid distribution is by doing an amyloid PET scan. Unfortunately, these scans were not approved for general use. They're still used primarily for research purposes, and Medicare and Medicaid and no third-party health insurance will cover this cost of a scan. If you were to pay out of pocket, it's probably about $4,000 to $5,000 to get this scan. We'll talk more about why it's not available for general use later.
All right, so now let's talk a little bit about how Alzheimer's disease progresses. So we're going to now look at a series of slides. They're all formatted similarly. Whoops, I was ahead of myself. Malcolm, I think you wanted to comment on this.
Okay. Well, just as we're going through these slides, I think it's important for you to know that the concept of Alzheimer's disease has really changed rather dramatically in the past 5 to 10 years. We now know, particularly probably since about 2010, that Alzheimer's disease seems to progress through 3 different stages. So there's what's called a preclinical stage, which we'll talk about, a mild cognitive impairment stage, and then a dementia stage.
Yes, and the preclinical stage is like a silent phase. So we're going to show you a series of slides. They're all formatted like this, and so you can see that the horizontal line represents time in years, and that the vertical line represents cognitive decline. So basically, the flat, straight green line represents our cognitive performance when we're young, okay? And this line is showing, the one that's sloping a little bit, is that all of us experience some changes in our thinking abilities as we age. So they're listed, a number of these changes. Some very common ones are, it just simply takes us longer to learn new information. This means that we might have to reread an article a couple of times to learn and remember and comprehend it. We're more susceptible to distraction. That means it's harder to focus when, for example, the radio's on or the television's on. We can't shut that out as well. It's harder for us to multitask or do 2 or 3 things at once. Again, we need to maintain our focus on a single thing. Now, the degree of these changes really varies from person to person. How many or how much of this change you experience is really dependent on things like your genetic makeup, how much education you've had, your physical fitness, and what your health status is, whether you have conditions such as hypertension, diabetes, or depression. that might be impacting your cognitive functioning.
Now, if the individual is starting to show these amyloid and neurofibrillary changes in the brain, these changes occur typically decades, at least a decade or more, before any cognitive or actual observable behavior changes occur. And this phase where there's pathology forming in the brain, but there's no observable symptoms, is called the preclinical or asymptomatic stage. And this represents a sort of a continuum from where there's absolutely no difference in the individual's performance, say on cognitive tests, to where there may be a very subtle or mild questionable change. This concept of a preclinical stage in a disease is very common in medicine. So for example, we talk about the buildup of cholesterol in our arteries. And you can have this cholesterol building up in your arteries and narrowing your arteries, and there may be no observable symptoms until at some point it becomes so severe you end up having a stroke or a heart attack. So this preclinical phase is not unusual in medicine. Next slide. For those individuals who are in the preclinical phase, sometimes they will be aware of a change. And this is where the individual is often forgetting things that they should know, or that they used to be able to do quite well, but now they're having difficulty. This is sometimes called subjective cognitive decline. And this subjective cognitive decline is a situation, it's not simple forgetfulness. So misplacing your car keys or forgetting the name of somebody you know is not subjective cognitive decline. This is more significant, where you're forgetting something that you usually should have been able to do or did well in the past. You go to the doctor says, well, I'm going to give you some simple memory tests, and the individual with subjective cognitive decline typically scores a perfect score. There's no evidence of any problem. So it's sometimes referred to as a stage where the individual knows something is not quite right, but others, the doctor, their family, don't think anything is going on. How frequently is this? Well, that's the focus of a lot of research. So currently, studies suggest that maybe 1 out of every 10 older adults maybe is experiencing this subjective cognitive change. Many times it can be due to other things besides Alzheimer's disease. Many times it can be due to things such as depression or anxiety or stress. It could also be due to things such as medication interactions. But sometimes it is due to the beginning of this formation of amyloid and tangles in the brain. The next phase is called mild cognitive impairment. How does this differ from subjective cognitive impairment? Well, in mild cognitive impairment, the changes in the brain, the tangles and the plaques, they are now at a point where they are affecting a person's cognitive abilities or functioning. Now the family, their doctor, are seeing a change. So typically at this stage, the individual is experiencing memory or other thinking difficulties that are abnormal in the sense that if I gave them an objective test, they would typically probably score in the bottom 10th percentile for their age group. They wouldn't be in the normal range, the 50th percentile. Family are seeing these changes. However, the individual is still able to function quite well in their day-to-day life. So the individual with mild cognitive impairment might be quite forgetful, but they can still go to the grocery store and pick up the items, maybe using a list. Maybe they can still do their billing and checking account, but instead of doing it in an hour, they're taking the whole day to do it. So they're less effective or efficient in doing these activities, but they're still able to do it. It's sort of like the absent-minded professor who's forgetful but can still manage quite well in their day-to-day life.
And so then we move into the phase of dementia. So the criteria for dementia you can see are listed on this slide. So there's a decline in intellectual ability, and that decline affects your memory plus one or more other thinking abilities, such as language, your ability to express yourself and to comprehend information, attention, reasoning, judgment, visual spatial abilities, such as our ability to find our way around in the world. And at this point, the impairment is so severe that it does impact your everyday functioning. So at this point, the person can't do their own shopping, they can't do their own finances, they can't pay bills, they can't drive, and then they start to be unable to do everyday skills such as dressing themselves, grooming themselves, and eventually being able to use the bathroom or take care of their most basic personal needs.
So I think an illustration to sort of illustrate how an individual could progress through these stages is often helpful. So let's take an example of, say, a car salesman, Joe, who in his best years, when he's high functioning and normal, he's able to remember, say, the top names of his clients, maybe the top 30 clients who consistently buy cars from him. And he knows what kind of car they like, he knows about their family, where they went to school, some of the names of their children. So he's doing quite well in his job and he's showing good memory performance. He starts to develop all of these plaques and tangles in the brain, and now he's into this preclinical phase. Nobody at work thinks anything is wrong, but Joe now finds he has to consult a little notepad about who his client's wife or children are and where they went to school and what kind of vehicle they want. He's still able to function at his job, but now he's maybe not remembering the information as well. Or maybe he's having some difficulty like calculating the costs of various additions to the vehicle that people are buying. He's still able to function. His wife can give him lists to go to the grocery store at the end of the day, and he can pay his bills. The plaques and tangles progress, and now he goes into mild cognitive impairment. At this stage, now he's really not being able to do his job very well, and his colleagues and coworkers are noticing the memory problems and forgetfulness. He's still able to work, but maybe now he's spending a lot longer at work trying to finish all of the paperwork and get things done. But his wife and his colleagues and his boss have now really noticed a change in his memory abilities. He continues to progress, and at some point he goes into a mild dementia, and at this phase he's forgetting important appointments, maybe he's showing some personality changes such as irritability or depression. He's really not able to do his calculations anymore or even keep track of what he's done during the past few minutes. So now he maybe goes into early retirement, and then over time, unfortunately, this disease would probably progress into the modern severe stages. But these very early changes that were happening back when he was still working, these are the biomarkers, the plaques and the tangles in the brain that are happening well before any symptoms became evident.
All right, well, how long does this process take? It's a very, very long process. As the silent phase, it can be 15 to 20 years or more. Once a person does enter MCI, that can range anywhere from 3 to as long as 8 years. And then the process of dementia, as you can see, can last from 5 to 8 years. Now, how many people with MCI actually progress to dementia? About 10 to 15% a year, so that by the time you're 5 to 8 years out, at least 60% of people who have been diagnosed with MCI actually progress into a full-blown dementia. And while I have the floor, I'm going to communicate with Malcolm that it's 6 o'clock. So he's aware, because he hasn't looked at his watch. And so what's the difference between Alzheimer's disease and dementia? We want to talk about that a little bit right now.
So this slide shows the major causes of cognitive impairment in older adults. And what you can see is that some of the cognitive impairments are reversible. Common reversible causes of thinking difficulties would include things such as medication side effects, metabolic problems like hypothyroidism, vitamin B12 deficiency, infections. There's non-progressive or static cognitive impairments. A good example would be someone who maybe has traumatic brain injury as a result of a car accident, or they have a single stroke. They may have a cognitive decline, but it doesn't necessarily mean that it will progress. But the ones we're most concerned about are these progressive and irreversible causes. And these would include many of the dementias, such as Alzheimer's or Lewy body, vascular dementia, frontal temporal dementia.
So this slide basically summarizes what we've been talking about. We describe what dementia is, and dementia is actually a big umbrella term, as you can see in the illustration, and it's great to think about it similar to cancer being a big umbrella term. When somebody says that they have cancer, usually your next question is, what kind? Because there's a lot of kinds of cancer, right? Pancreatic cancer, breast cancer, lung cancer. Well, similar with dementia. When somebody says you have dementia, our next question ought to be, well, what kind? All right? And so the slide Malcolm just showed you the many, many different causes or types of dementia. We just know that Alzheimer's disease is the most common cause, and that there's a transition from what we consider normal to Alzheimer's disease, and that transitional zone, or that borderland, is called mild cognitive impairment. So this slide shows you and makes the point that Alzheimer's disease accounts for most dementias. 55% in the red part of this chart are due to Alzheimer's disease. The second and third most common causes of dementia, somewhat competing for second and third place, are what's known as vascular dementia, or related to mini strokes in the brain and changes in the vasculature, and then dementia with Lewy bodies. And we don't have the time to go into describing what that is, but this is a type of dementia that appears to have some similarities with Parkinson's disease, but is not Parkinson's disease because of its symptoms. So, and then there's a few other causes related here, traumatic brain injury, and then other types of dementia like frontotemporal dementia. This is Dr. Alois Alzheimer, the German neuropsychiatrist who was first to identify Alzheimer's disease in Augusta Dieter, who is pictured here, who came to him at age 51 and was brought to him by her husband, Carl, who thought she was going mad. And she died 5 years later, and it was actually at her autopsy that Dr. Alzheimer first identified the plaques and the tangles that we showed you earlier. So just a little bit about Augusta Dieter and her symptoms. She had symptoms that we very much are associated with Alzheimer's today. She'd stored mail under her bed. She was stashing items around their apartment. She was accusing her husband of having an affair, going on walks with other women. She was neglecting her housework and unable to do her cooking. And she was wandering aimlessly around their apartment. Now, because Augusta Dieter was 51 years old, it was thought for many decades that Alzheimer's disease was actually very rare, and most cases of dementia were either attributed to senility, oh, the person's just growing old, or to arteriosclerosis. And arteriosclerosis is a chronic disease in which thickening, hardening, and loss of elasticity in the arteries walls results in impaired blood circulation and therefore would cause changes to one's thinking abilities impacting the brain. So we gave you a handout with the 10 warning signs of Alzheimer's disease. And just to note, it's very important to recognize the warning signs of the disease, which are described on the handout, and for anyone who's experiencing any of those to go in and see their doctor and get evaluated. And really do not ignore these warning signs. There are many reasons that persons have difficulty in memory and thinking, and the most important thing is to go into the doctor to figure out what's causing the memory and thinking difficulties and get it treated, because it isn't necessarily always Alzheimer's disease. It could be something else. So how do we diagnose mild cognitive impairment and Alzheimer's disease? Well, first of all, just a few comments about that is, unfortunately today, your general practitioner, meaning primary care physician, still often misses MCI and Alzheimer's disease. And in fact, studies have shown that doctors tend to miss 76% of individuals who already have a moderate dementia, and 9 out of 10 individuals with early symptoms. Specialists and expert centers do a much better job 90% of the time correctly identifying Alzheimer's disease. There's also a lot of misconceptions that contribute to under-identification of the disease, and these really create a barrier. And one of the most common one, still held by older adults themselves and held by healthcare professionals, is that Alzheimer's disease or changes in one's thinking and memory abilities are just a normal part of aging. So remember, age increases your risk, but it does not mean that you will necessarily get Alzheimer's disease. There's some other misconceptions, and we do live in a multicultural community here, among minorities, for example, who might attribute the changes due to Alzheimer's disease to mental illness, or perhaps to karma, or one's fate. So what we need to do is create much more public awareness and understanding of the disease, so that it can be better identified and individuals can be treated early.
So what does a diagnostic evaluation entail? Well, the goal of the diagnostic evaluation is really to separate normal aging from individuals who perhaps have this subjective cognitive decline or mild cognitive impairment or dementia. But at the same time, we also want to identify any other contributing factors that could be worsening their cognition. So for example, maybe the person has dementia, but they're also severely depressed. And we know depression can worsen memory and cognitive ability. So we want to identify that and treat it. Or if they've got a B12 deficiency, or a thyroid is poorly managed, or diabetes is poorly managed. So we want to address things that are potentially treatable and reversible, as well as things that maybe are not, such as Alzheimer's dementia. There is no single test that you can run that will tell you whether you have one of these cognitive impairments. The diagnostic process today is where there's multiple components, and we use all of those components sort of like a jigsaw puzzle. You have to put them all together in order to tell what the final picture is, or the diagnosis. So these are the major components of the diagnostic workup. So initially you start with a good medical history. You want to know what are the symptoms, how did they occur, what symptoms occurred first. So for example, in Alzheimer's disease, memory problems are often reported first. In Lewy body, you may have motor changes or physical changes. Secondly, you want to do some a neuro exam. You want to be able, the neuro exam helps to detect things like Parkinson's disease or stroke. You want a blood work and urinalysis to detect, is there any infections? Are there deficiencies in certain vitamins or metabolic problems like thyroid? You also want to most likely do some kind of brain scan, like an MRI, to detect is there stroke or is there shrinkage in the brain. You may do a PET scan. That looks at blood flow and metabolism, because certain disorders have different patterns on a PET scan. And also you would want to do some cognitive testing. These are things that will actually tell us about the person's memory or language or thinking abilities. Many times we'll have a patient come in who will say, oh, doc, my memory is abysmal, and I can't remember anything. And you actually do your cognitive testing and they turn out normal or above average. So they're sort of the worried well, and maybe they're comparing themselves to how they were when they were a 20-year-old instead of a 70-year-old. So you want the cognitive test to tell us, is there a problem there? Yes or no? Also, is the pattern that we're seeing in terms of what the person's strengths and deficits are they suggestive of a particular disorder like Alzheimer's disease?
So this is just an example of a particular cognitive test, and here the examiner at UCI Mind is giving this individual a test of visual spatial abilities, where the individual actually has to arrange the blocks to copy the pattern that's on the booklet.
If we did an MRI scan, what we might be looking for is evidence of shrinkage or strokes in the brain. And so this is just an MRI scan looking straight at the person. So their ears will be along the sides. This region here is the temporal lobe, and this little area highlighted by the yellow arrow is the hippocampus, and we have one on each temporal lobe. And these sort of cartoons, schematic cartoons, are showing how the hippocampus and other areas of the brain could show some shrinkage over time. And so as you can see, this outer surface, which is the cortex, where a lot of our thinking abilities take place, we're seeing some shrinkage over time as they go from the mild to the moderate and in the very severe stages. And the hippocampus is showing a corresponding shrinkage until in the late stages, there's nothing there. This is just showing actual MRIs of the same individuals over time, going from essentially minimal or no change to mild, moderate, and severe atrophy. And the decline in the MRI scan paralleled what you would see on the cognitive tests. So we spent a long time talking about these biomarkers. Well, why don't we use biomarkers in our diagnostic process at this point in time? We may use them in the future, and they may be very valuable. What we know is that these biomarker changes occur, this is a time, and this is the changes in the biomarkers, but they occur many years before any cognitive changes, the green area. And this is the biomarkers for CSF, for amyloid in the CSF, and this is an amyloid PET scan. And you can see they are changing decades before you see any cognitive changes. This is changes on an MRI scan, which occur much later than do the biomarker changes. So why don't we use these biomarkers currently? So I already showed you the picture of the amyloid scan with the amyloid showing up in the brain of someone with Alzheimer's. And this is what we would like to see. This is sort of the ideal situation where a healthy adult shows virtually no amyloid in the brain, the red and the bright yellow. An MCI patient shows an intermediate amount of amyloid compared to an Alzheimer's patient. So if this is what you got on every scan, you could certainly say, well, why don't we just do an amyloid scan and forget all of the other components like the cognitive testing or the neurological exam or the brain scan. Well, unfortunately, this isn't what you get, that idealized situation. But what you find is that these are amyloid scans from individuals who are normal, MCI, and Alzheimer's dementia. And what you can see is some normal adults show very little amyloid. Some show rather extensive amyloid in the brain that actually could be mistaken for someone with Alzheimer's disease. Yet this is a healthy, normally functioning older adult. Some MCI patients show essentially no difference between a healthy control, and some do show extensive amyloid. So the next slide shows the percentage of individuals in each of those three groups who show positive amounts of amyloid in their brain. And you can see that in a normal healthy adult, 25 to a quarter to almost 35%, or a quarter to a third of normal older adults can show extensive amyloid in the brain. So if you were making your decision based on the presence of amyloid, and you said, oh, amyloid means Alzheimer's, you would be telling these healthy adults that they have an Alzheimer's brain. Do those individuals who had amyloid who are normal adults, maybe they are in that preclinical phase of the disease where they're able to function well, but there's amyloid forming in the brain? We don't know if that's the case. We also know that there can be some healthy older adults who are very active into their 80s and 90s, no changes in their cognition. They come to autopsy, for example, at our clinic. We have a healthy control program. And we've had a number of cases where we have someone who's in their 80s and 90s who is functioning very well independently. They come, they pass away, they get their brain autopsied, and the pathologist who knows nothing about their cognitive scores will say, oh, this brain is classic Alzheimer's disease. And yet they're a high-functioning normal adult. If that individual had lived into 100 and older, would they have developed Alzheimer's? We don't know. So we don't know if some older adults can have amyloid in the brain and that's a normal variant of the aging process. Or are they in this preclinical phase of the disease?
So we want to talk now a little bit about treatment. So a very important statement from Pierre Tarot, who has worked in this field for decades. Dementia may not be curable, but it is treatable even in its advanced stages. So perhaps the most important point on this slide in terms of the history of medication development, drug development for Alzheimer's disease is that you see here again, it was 1906 when Dr. Alzheimer first described Alzheimer's disease in Augusta Dieter, and it was 1993 before we ever had a drug for the disease. Now you'll remember that's 9 decades. You'll remember I mentioned that originally it was thought to be a very rare disease, and it wasn't until the 1970s that it was realized that Alzheimer's disease is actually the most common cause of thinking difficulties in older adults, and that that arteriosclerosis was not the primary cause. So then in the subsequent years, we don't use Cognix anymore because it had some toxic side effects. We have developed additional drugs, and there have been 4 additional drugs that have been developed, and we'll talk about those briefly. But since 2003, when the last drug, Namenda, was approved, there have been 244 experimental drugs that have been tested and over 400 clinical trials without us being able to find another effective medication. And we'll explain why we think that's been the case as well. So first, Malcolm's going to talk a little bit about the acetylcholinesterase inhibitors, which are Aricept, Exelon, and Razidine, and how they work.
So you have a handout in your pamphlet that shows the major, actually the 4 drugs that are approved by the FDA. And in the past, we would spend a whole session just going through these drugs and talking about them. But I think there's 2 classes. There's the acetylcholinesterase inhibitors, and those include some drugs you may have seen commercials on the TV related to, such as Aricept, Exelon, and Razidine. And then there's a second class the one Cordula mentioned, Namenda, which is working on a different neurotransmitter than the acetylcholinesterase inhibitors. But essentially, the three drugs, Aricept, Exelon, and Razodine, what they're trying to do is they're trying to essentially boost up the level of the neurotransmitter. The neurotransmitters are the chemical messengers that allow one brain cell to send messages to the other. And this chemical messenger that's depleted in early Alzheimer's disease, anywhere from 40 to 90% is acetylcholine. And the drugs differ in how they're administered. Some are given once a day, some twice a day. Exelon can be given in a patch form, a transdermal skin patch. They also differ in their side effects, and on the back of that handout shows the most common side effects listed or associated with each of the drugs. And then you have Namenda, which is the last drug that was FDA approved in 2003. And Namenda is an excitatory transmitter. It's working on a different neurotransmitter called glutamate. And glutamate is very prevalent in our brain, and it helps to essentially keep your brain cells active or stimulated. Now, what happens in Alzheimer's, many patients have too much of this glutamate, and you might say, is that bad? Well, actually it is, because if you have too much, your brain cells are in a state of sort of like overdrive, where they're hyper-stimulated, and this can produce something that's sort of called excitotoxicity, where you're actually essentially burning out or destroying the brain cell. So what Namenda does, if you've got too much glutamate that's toxic to the brain, it lowers the level of glutamate and thereby has a protective effect on your brain cells. Both Namenda and one of the cholinesterase inhibitors can typically be given together, particularly in the moderate to severe stages, because they're working on totally different neurochemicals or transmitters. So, what do these drugs do? Well, unfortunately, they're just symptomatic treatments. They're only changing the symptoms. They're not altering the disease course. They're not changing what is happening with those plaques and tangles in the brain or the shrinkage of the brain. The benefits are only seen so long as you take the drug. If you stop taking the medicine, the benefits will disappear, usually within a matter of a few days to a couple of weeks. Do all patients respond positively? Well, they don't. Probably about 60 to 80% of individuals who are treated with these drugs show a positive benefit. What is that positive benefit? Well, typically it is not necessarily an increase in their memory or thinking abilities, but rather some form of stability where they may be relatively stable for a period of time and maybe not show as much change over time as someone who is not treated with the drug.
Really important is to be realistic about what these medications can do. So unfortunately, a lot of individuals who take these medications actually stop within 4 to 6 months of starting. And you know, there's difficulty with compliance, and there's a lot of factors that impact compliance with the medication. The fact that the individuals have advancing age, they might have other multiple medical conditions that are affecting them. They might simply forget to take the medication because of their cognitive impairment, or caregivers might just be so stressed and burned out, or there might be some behavioral difficulties if the individual's, for example, refusing to take the medication. But another issue is the unrealistic treatment expectations. We have to understand what the drugs can and cannot do. And they cannot cure the disease. They do not change the progression of the disease, but they can boost the person's functioning. They can help them to function more independently. Even simple things like I've had caregivers tell me, oh, my loved one is communicating better. And they can also help reduce behavioral symptoms in some cases. Some of the restlessness or agitation, anxiety, some of the apathy or lack of motivation, and even some of the more psychotic features, the delusional thinking, can be helped. And studies show that people who stay on these medications actually have delayed nursing home placement because the drugs are helping to keep them more independent. And we just have to realize that sometimes the fact that the person isn't changing or is staying stable means that the drug's working. So even if you're not feeling like that person's improving, just the fact that they're staying stable and they're not declining is a benefit. So this is just a summary slide again, showing what the current treatments are. And so you can see for mild to moderate Alzheimer's disease, the acetylcholinesterase inhibitors, Aricept, Exelon, and Razidine. Aricept has actually been approved also to be used in severe Alzheimer's disease, and Namenda is specifically for individuals with moderate to severe Alzheimer's disease. Whoops, I'm sorry, I jumped ahead here. So I couldn't get it to work, and then it wanted to really work. So what are our goals of treatment here? When we think about the treatments that we have today and future treatments, what are the potential goals? Well, of course, what everybody wants is a cure. At least we want to be able to maintain the person over the long term. We'd like to have a drug that slows the progression or actually changes the progression of the disease. Today's drugs actually are symptomatic. They boost up the person's functioning, but if the person's taken off the drug, they would go back to the natural progression of the disease. So today we're trying to find these drugs that are going to slow progression, maintain functioning, and ultimately cure the disease. So what we're also attempting to do is move treatment leftward. One of the issues when we talked about the fact that these treatments aren't as effective as we like is that today we're treating people oftentimes when they're in late MCI, when they're already in dementia. What we need to do is move treatment back to this pre-symptomatic, preclinical phase when there's no symptoms. So going back to the example of heart disease, your doctor doesn't wait until you've had a heart attack or a stroke to treat your heart disease. They're treating that when they give you medications to lower your blood pressure, medications to lower your cholesterol. And like that, we need to be identifying treatments that we can give when those biological changes are first starting to occur.
I just want to talk about two clinical trials that we actually have either starting up or ongoing at UC Irvine Mind Center. And both of them are dealing with what are called monoclonal antibodies or amyloid. And monoclonal antibody is a process where you develop in the laboratory a molecule that will attach to, say, a cancer cell, or in this case, amyloid, and help to clear it out. And there's a drug that we are in the process of getting approval to do our clinical trial with, and this is called aducanumab.
Nothing's easy to pronounce, is it?
So you can use that next time you play Scrabble. But this is a drug that was tested by a company, Biogen, and they released the results in 2015. And essentially what it showed is that the patients given this monoclonal antibody showed a reduction in the amyloid plaques in the brain compared to patients who were on the standard treatment, such as Namenda and Aricept. But more importantly, they also showed an improvement in the cognitive functioning of these individuals. And so now they are taking it into this next phase 3 trial. And this is, on the next slide, this is involving 1,350 patients with mild dementia or MCI, most likely due to Alzheimer's. They're giving them either a placebo. The placebo in this case would be just an inert substance that is given through an infusion once a month. These individuals are on their current treatment regimen, so they don't have to go off their drug if they're on Aricept, so they're given a placebo and their current treatment, or they're given their current treatment plus this monoclonal antibody. And this is you can see it's an extensive 18-month trial. They come in once a month for an infusion where they get the drug or the placebo. And then they're going to be measuring cognitive changes and also using one of those amyloid scans to detect changes in amyloid in the brain over this 18-month period. So there's 1,350 people being recruited at a number of sites in the United States and Canada, and then there's also an equal number being recruited in Europe and Australia and Asia. And this study is expected to run until about 2022. The age range is individuals age 50 to 85. It's not being on, this study has only been recently started. Unfortunately, all of the mild AD patients slots have been taken, and now they're recruiting mainly MCI patients. Typically, to be in part of this study, you would get an amyloid PET scan at the very beginning, because if you don't have amyloid and you have an MCI, you may have MCI due to some other cause. The second trial is an exciting trial. This is called the A4. And A4 stands for Anti-Amyloid Treatment in Asymptomatic Alzheimer's Disease. So this is actually a prevention trial. And we are recruiting subjects. This is an ongoing trial, not only in the United States, at UC Irvine, but at 61 other centers in the United States. This is a trial using people who are in that preclinical asymptomatic stage. So when you enter this trial, one of the first things that is done, besides some cognitive tests to make sure you're normal, they also do an amyloid PET scan. Individuals who don't show any amyloid, they're not going to be a part of the trial. If they do have amyloid, they could then be entered into the trial and they would get another monoclonal antibody monthly. This is called solanezumab. And this is a 3-year study. So they would come in once a month for 3 years, get the antibody infusion, which takes about 30 minutes, and they'd be tracked over time. The goal is that if this monoclonal antibody can remove the amyloid in these individuals who are in the preclinical phase, they may never need to go, or they may not go into the MCI and dementia. So this is a really exciting study because it's the first worldwide test to see if we can prevent someone from developing Alzheimer's disease. This is a listing of various websites you can go to that can give you additional information about these clinical trials. We also have information at our clinic. By calling our clinic number, we can connect you to our clinical trials coordinators who can tell you more about these trials if you're interested in.
And you can certainly give your name to Chelsea and the staff if you'd like to have some follow-up about participating in clinical trials. So we don't want to forget to mention today that such an important part of the treatment of Alzheimer's disease is all the services that individuals need and that families need during the entire course of the disease. And you can see that they're broken down here by stage. And they range everything from education and support groups for individuals themselves in the early stages, care management, adult day services, home care, alternative living environments, and certainly services to support people as they move towards the end of life with hospice. But I do want to take a moment to communicate with my co-presenter and ask. We have 25 minutes left, and hopefully we want 10 minutes for questions, so we have 15 minutes, and How would you like to proceed? Because as usual, we have more information that we can get through, and we want to talk a little bit and highlight for you 5 key strategies for reducing your risk of Alzheimer's disease.
So, some of the information is on the slides, and in those ones we won't sort of go into great depth because it's on the slide for you.
All right, so in other words, we're giving you a crash course. All right, very briefly, we're going to talk about the importance of controlling cardiovascular disease and diabetes. And if you are leaving for any reason, please fill out your evaluation form. We're going to talk about eating a healthy diet, exercising, staying mentally active, and staying socially active. So first of all, in terms of cardiovascular disease, 1 in 3 people in the United States have high blood pressure. And this is simply a chart that illustrates for you what normal blood pressure expectation would be, which is again below 140/90. So we really want to stay down in this range of 120/80. And you can see the various levels of hypertension provided for you. So we do know when we look at studies that have been done, and we look across studies, we know that hypertension will increase your risk for Alzheimer's disease and dementia anywhere from 3 to 5 times. And the important key word here is midlife. And what you're going to see throughout these slides is that what you do when you are younger affects the health of your brain when you're older. We also know when we think about hypertension, the higher that top number is, what's considered your systolic blood pressure, the more at risk you are. And if you treat your hypertension through lifestyle or medications, you can reduce that risk again.
Another factor related to cardiovascular risk is your cholesterol. And you all probably know that you want your cholesterol, total cholesterol, to be under 200. But the most important aspects are looking at the ratio between the good cholesterol, the HDL, and the bad cholesterol, the LDL. And the good cholesterol essentially is what we use to try to get rid of the bad cholesterol. The bad cholesterol, the LDL, sort of sticks to the wall of the arteries and causes a blockage. And the good cholesterol, the HDL, essentially sweeps that away, takes it down to the liver, and removes it.
So you can see there that high cholesterol affects 1 in 3 Americans, and that a large number of people remain untreated or are receiving treatment or not at goal. And it's very important to have cholesterol treated. Just when we look at Alzheimer's disease, again, we're looking at risk, high cholesterol in midlife, and again, across studies showing that high cholesterol increases your risk about 2 to 3 times. When you combine that with high blood pressure, it further increases your risk. And in fact, low HDL in and of itself, below that cutoff of 60, has been linked to memory decline. So keeping that HDL up is very, very important. So again, we've got a lot of lifestyle strategies that we can use to help us keep our cholesterol in check. In terms of diabetes, just the brief 101 on diabetes is that there are 2 types. Type 1 diabetes used to be called juvenile diabetes, versus type 2 diabetes, which diabetes that any of us are at risk for. In type 1 diabetes, the body does not produce insulin. It's a hormone that's very important in converting food, starches, sugars, into energy that our body can use. In type 2 diabetes, again, the kind we're at risk for, all of us are, the body is either not producing enough insulin or it's not using the insulin effectively. And diabetes has many negative health consequences. And one of those is to increase your risk for Alzheimer's disease. Here you can see the most current statistics on diabetes with 29.1 million people affected and 86 million being pre-diabetic. In fact, there was just a study that was released by UCLA that indicates that half of Californians are pre-diabetic, which we know is directly related to the issue of obesity and our epidemic of obesity. So what do we do? This slide shows us again that increased risk, doubling our risk for dementia. And then you can see that it doubles risk approximately for Alzheimer's disease and even further for vascular stroke-related dementia. There was a study that just came out that showed that type 2 diabetes increased your risk for Alzheimer's disease by 60%. And again, when you have these conditions in combination, it's further increasing your risk. But also, good message here is, again, treat your hypertension, treat your diabetes. You can help offset some of that risk. Lots of lifestyle strategies, and these lifestyle strategies cut across the board. Eat a healthy diet. So what in the world does weight have to do with it? And I'm sure you're all familiar with BMI, a body mass index. It's a measure of our fat in our body that's based on our actual height and why am I blanking? Age, thank you. That just went right out of my head. Height and age. That's right. Between Malcolm and I, we've already had 2 word-finding problems, right? See, you can tell, those of you who've been coming here for a while, you can tell we're getting older too, right? All right. Here, just quickly, the research here has been very interesting. For a number of years, the thought was that the more overweight you are, the greater risk you are for Alzheimer's disease. Certainly some of the evidence pointed to that. This recent study that's summarized here, where they looked at a person's weight at different decades, and again, they're looking at a whole group of 450,000 people. And look at that. At between age 30 and 39, if you were obese, your risk was increased 3.5 times. By age 70, it didn't matter if you were obese. And by age 80, you were actually at 22% lower risk. Now, another study along the same line looking at 2 million primary care patients, and again, these are older adults, older than 40, I believe, that were followed for 9 years. The individuals who were obese actually had a lower risk of developing dementia, and guess who had the higher risk? It was the individuals who were underweight. It was the individuals who were underweight that was at 34% greater risk. And we mean underweight, not thin and with a normal BMI, but with a BMI that's below 20, underweight. So it looks like a little padding as we get older is okay. He's shaking his head like I'm on a roll. Is that what you're doing? Yeah. He's like, I'm done. You just keep going. All right. There's 2 kinds of diets we want to mention. First of all, the Mediterranean diet, and you can see it illustrated here. Again, a couple of studies that show that the Mediterranean diet, which is characterized by eating a lot of whole grains, fruits, vegetables, olive oil as your primary source of fat, a little wine, some fish, but guess what? Not too much red meat. Reduced risk by 40% for dementia. And it's been fairly consistently shown across studies that the Mediterranean diet reduces risk. Now we're going to talk about the MIND diet. You have a handout. Unfortunately, we meant to put that nice green handout you have on a slide, but we forgot to do that. And if you can focus on that handout, the scientists actually went to the literature and they looked for all the nutrients that have been associated with less risk for Alzheimer's disease. And they said, let's put together a diet that uses all these particular nutrients, okay? And the MIND diet, can I borrow somebody's green sheet? Yes, thank you. So you can see, look on your green sheet, you can see the foods that, if I held it up right, you can see the foods that are okay to eat. And in fact, you ought to be eating and have been associated with lower risk for the disease. All that good healthy stuff like nuts and green vegetables, whole grains, fish, olive oil again for your source of fat, a little wine. And what you don't get to eat is all that fun stuff, red meat, cheese, butter, pastries, fried food. Give it up, guys. It's not good for your brain. If you look, and that's summarized in this slide, but if you look at the main bullet points here on the handout, you'll see that people who highly adhered to this diet, closely adhered to it, had a 53% lower risk of Alzheimer's disease. And guess what? If you only adhered to it sort of, so-so, moderately, you still had a 35% less risk of Alzheimer's disease. So eating a healthy diet matters. And eating a healthy diet also helps reduce your risk of diabetes and cardiovascular disease.
One of the components of the diet...
he wants to talk now. Go. I'm fine.
Okay. I was going to help you out.
I had to say that. Go ahead, Malcolm.
So one of the components of the diet, both in the Mediterranean diet and the MIND diet, is fish. And there was a study done about 13 years ago where they looked at a large group of older adults. These were in their mid-60s to mid-90s. And they looked over a 4-year course of what their average diet entailed. So they filled out questionnaires. And one of the interesting findings is that they found that individuals who were eating fish once or twice a week showed a 60% reduced risk for developing dementia during that 4-year course of the study. Another study, which is on the next slide, this was actually looking at normal adults, and they were looking at the benefits of fish in terms of cognitive functioning. And what they found, they did multiple MRI scans over a 10-year period, and they found that those normal adults who were eating fish at least once a week, they showed increased brain volume in certain areas of the brain, particularly the hippocampus. They showed a 14% increase in the volume of the hippocampus. And they also showed some increase in the frontal lobes, which are involved in things like planning, organization, reasoning, and judgment.
So the major concern for most people, sorry, that sun is right at me, is that that fish might have contaminants. So you can look on www.mercury.org to look at levels of contaminants, but bottom line is the best way to get rid of contaminants is to skin the fish before you cook it. So we are really...
Why don't you jump to the exercise?
Okay. So you have information on vitamins that you can have in your slides and can look at, but we do want to go ahead and just talk briefly about exercise. And the most important thing about vitamins is talk to your doctor about them. So just briefly on exercise. First of all, when we talk about exercise and reducing your risk for Alzheimer's disease, we're really just talking about getting the recommended amount of exercise. It's now recommended that we get about 30 minutes of exercise most days of the week, and we're talking about things like walking, not necessarily having to go and break a sweat. It's really more important how long you're active than how hard you exercise. And there are a number of studies that are listed on this slide, and there are many more studies than this that have shown that exercise benefits the brain. In fact, some of the strongest scientific exercise is actually for, strongest scientific evidence is actually for exercise. And again, as simple as walking regularly.
If you're really interested in exercise, I would recommend that you come to one of the distinguished lecture series, which is being given next week. It's a Dr. Laura Baker, and she is sort of one of the leading individuals who's done research on the benefits of exercise for older adults and their cognitive functioning. And I think they probably have some handouts for you to take, or we can get them to you. But going back to the amyloid in the brain, one of the benefits that we're discovering with exercise is that when individuals exercise, their pituitary gland releases certain hormones, but one of the benefits is that by exercising, you cause your brain to release a growth hormone. It's called brain-derived neurotrophic factor, or BDNF. BDNF is like a repair mechanism for our nervous system. It helps to repair damaged brain cells, and most importantly, it's also been shown to help remove amyloid. So that's why individuals, for example, who are older adults who are engaged in a regular exercise program, they have a reduced risk of developing MCI and dementia. And individuals who have mild cognitive impairment who are regular aerobic exercisers, they have a reduced risk of transitioning into dementia than those who are non-exercisers. So exercise not only helps your cholesterol, your heart, but they also can lower our risk of cognitive impairment.
So we know from this study that exercise plus diet was the most beneficial, and you have that information on your slide. We want to just say that it's also important to engage in mentally stimulating activities to exercise your brain. And so most importantly is get off the couch. There's actually been several studies now that have shown that watching a lot of TV is actually bad for your brain. And in this one, people who developed Alzheimer's disease in midlife spent an average of 38 hours a week watching TV. That's 5 hours a day almost. Those who stayed healthy were only watching half that much TV. And also, in a study that was done in China, we saw a very similar pattern. Those who stayed healthy watched less TV, they played more board games, and they spent more time reading per week. We also know that getting comfortable with using the computer can benefit your brain, and this was an interesting study in which they looked at older adults who used the internet and email regularly, those versus those who just used it once in a while. And those who used it regularly actually did better on a memory task than those who did not. We want to mention being socially active. Again, repeatedly studies have shown that a limited social network is increasing risk for the brain. And there's 3 studies there that have demonstrated that. So we really want to emphasize staying physically, mentally, and socially active, how important activity is for the brain. And just a few last tips. We know that head trauma is bad for the brain. Of course, you've all heard about the issue regarding playing football and concussions and subconcussive injuries, but even in older adults who experience a fall and a fall-related injury increase their risk for developing dementia. You can see smoking is associated with Alzheimer's disease, as well as stress. Malcolm might want to make a comment about sleep.
Sleep has gotten a lot of attention, and one of the discoveries is that, remember we talked about how the healthy brain sort of washes away the amyloid in the CS3 or spinal fluid. Well, a lot of this cleaning process takes place when we're asleep, particularly when we're dreaming. So individuals who have poor sleep patterns or fragmented sleep, they have an increased risk for developing cognitive impairment. So we would be advocates for trying to get a good night's sleep, because that's actually a way that your brain does a repair mechanism. So 7 to 9 hours if possible. Try to avoid the use of sleeping aids, which is in the next slide.
Well, I just want to mention that my husband, who is a night owl, has actually started going to bed to sleep because he knows that it's going to help clear out the amyloid from his brain. So
It's too late for me.
all right. Just quickly, we also need to attend to depression. If you've experienced depression during your lifetime, significant depression, that can increase your risk up to 4 times. Even if you experience depression for the first time as an older adult, that can double your risk. And just briefly, we really need to not be using these sleep aids on a regular basis. There was a study done last year that found that individuals who were using these types of sleep aids on a nightly basis over a 3-year period were increased risk for dementia. So if you need a sleep aid, use a natural substance like melatonin or talk to your doctor. So, but the main 5, our main 5 we've talked about today, we'd like to encourage you to adopt, and we'd like to encourage you to do those things together to get the most benefit. So thanks again for being here. Please fill out your evaluation forms.
I did.
Yeah.